Good morning, everyone. Thank you. Welcome to the Frontenac County Council meeting of Wednesday, May the 21st. I'd like to call the meeting to order. We begin this gathering by acknowledging and celebrating these traditional lands as a gathering place of the First Peoples and their ancestors who are entrusted to care for Mother Earth since time immemorial. We do so respecting both the land and the Indigenous people who continue to walk with us through this world. Today, the county is committed to working with Indigenous peoples and all residents to pursue a united path of reconciliation. Closed session.
Moved by Councillor Smith, seconded by Councillor Vandewaal. Resolved that council resolve itself into committee of the whole closed session as authorized under section 239 of the Municipal Act to consider adoption of closed minutes of meeting held January 15th, 2025, and labor relations or employee negotiations as it relates to attendance management.
Any comments? In favor? Carried. We're into closed. To call this meeting to order. Welcome to Frontenac County Council's regular meeting, May 21st. Call to order. We begin this gathering by acknowledging and celebrating these traditional lands as a gathering place of the First Peoples and their ancestors who are entrusted to care for Mother Earth since time immemorial. We do so respecting both the land and the Indigenous people who continue to walk with us through this world. Today, the county is committed to working with Indigenous peoples and all residents to pursue a united path of reconciliation. Okay, so we've come out of closed session.
So there is a motion for that, Warden Lichty. It's moved by Councillor Fowler and seconded by Councillor Leonard. Resolved that council rise from committee of the whole closed session without reporting.
Any comments? In favor? Carried. We have no addenda. Is there any disclosure of pecuniary interest and general nature thereof? Seeing none. Adoption of the minutes.
So for the minutes of April 16th, that is moved by Deputy Warden Saunders, seconded by Councillor Gowdy. Resolved that the minutes of the regular meeting held April 16th, 2025 be adopted.
Any comments? In favor? Carried.
And for the minutes of May 14th, there has been one slight amendment. Councillor Leonard was present at that meeting, so that the minutes now reflect that. So that's moved by Councillor Greenwood Spears, seconded by Councillor Smith, that the minutes of the regular council meeting held May 14th, 2025 be adopted as amended.
Any comments? In favor? Carried. We have no delegations and presentations. We have no proclamations. We now need to move into the committee of the whole.
Moved by Councillor Vanderwall, seconded by Councillor Fowler, that council adjourn and meet as committee of the whole council with the deputy warden in the chair.
Any comments? In favor? Carried. Bill?
Good morning, everyone. With council's permission and to respect Dr. Morrison's time, what I'd like to do is move to recommended reports from the Chief Administrative Officer, clauses A, B, and C. Seeing no objection, what I would like to do then is introduce, or like to call Ms. Debbie Miller to the podium and introduce her guest.
Thank you and good morning. And I would just like to take a moment to introduce Dr. Kim Morrison, the executive lead with the Frontenac, Lennox and Addington Ontario Health Team, the FLA OHT. With extensive experience in the healthcare sector, she's a family physician, an associate professor in Queen's Department of Family Medicine, and the chief of staff at the Lennox and Addington County General Hospital. She develops strong, positive working relationships across sectors and community settings. She believes strongly in teams and collaboration. Leading the FLA OHT is an opportunity to work together with community members and healthcare partners on transforming our healthcare system, building on a solid foundation in primary care. Dr. Morrison is going to provide an update for the FLA OHT, as well as recent funding application the OHT submitted. After the update, there'll be an opportunity for questions, and I'm going to turn it over to Dr. Morrison with a PowerPoint on the screen as well with a few details there. Thank you.
Thanks so much, Debbie, and thank you to all of you. I haven't had a chance to meet you all, but it's really nice to be invited to come here and to talk about our OHT and how that really is about the people in the communities that we serve. And I've done a lot of work with our OHT and have read the report that you've commissioned Mr. Wood to put together. And it really brings joy to my heart when I see all of these things coming together in terms of the collaborations that we can do together to really make it so that the people in our community that we all care for in different ways can have their best health and wellness outcomes that they can. I thought what I'd do, Debbie sent me a bunch of questions that I know you're interested in, and a lot of it stems out of the report that's been commissioned and the implementation plan you're going to talk about after. What I was hoping to do is just tell you a little bit about the background of the OHT, Health Homes, Health Neighborhoods, the Primary Care Action Team and its mandate, the work that the OHT has done to date, and then happy to dive, but that's going to be pretty short, just as background to set the stage. And then happy to walk through any questions that I might be able to answer, or I can certainly take back if I don't have the answers myself, because certainly it changes all the time with the ministry, as you know, from the other ministries that you all deal with. So with no further ado, these are the things that I thought we could talk about today. What health homes and neighborhoods are, what this mandate is, how we can build capacity in primary care, which was really the thrust of the work that you're doing in terms of family physicians and primary care in Frontenac counties, and what collaboration looks like. Nobody can do this on their own. It takes all people coming from all different parts to come together, but I'm quite confident that we can do it. The OHT in Frontenac, Lennox, and Addington was one of what was called cohort 2. So we were the second round of approved OHTs. It was in the fall of 2020. It's kind of crazy that we're in our 5th year. This is the mission out of our strategic plan that we built in 2021-22. And it's really around creating a people-centered health home for everybody in our counties. Very briefly, this is our organizational structure. In 2023, where we were identified as an accelerated Ontario Health Team, one of 12 in the province based on the work that we'd done to date. And at the time, as you may have heard through previous meetings about a year ago, there was a real push towards incorporating the OHT and really focusing on governance. And that was leading towards something called designation. Ontario Health Teams at the moment are coalitions of the willing. There are no carrots, there are no sticks. There's a joint vision and joint thought of how do we work together towards the people that we serve. There are no rules at this point. We have something called a transfer payment agreement from the ministry, and each year the ministry outlines what their priorities for OHTs to achieve are. And we work together as a coalition. We work on consensus decision-making to come together towards achieving those goals. This is the structure that we've had to date. We took the opportunity around the conversations about governance to say, how can we work better together now that we're in our 4th and now 5th year? The government has since said, stop all governance conversations. Don't talk about that. Talk about attachment and access to primary care. But we did a lot of work, and we're going to use that work that we've done around how do we work better together. So we have a we have a retreat coming up in June that will really help us land on who are the people that should be sitting at what tables, including counties like Frontenac. How do we make sure that the voices of our community are involved? And how do we ensure that all of the work groups that you see here all feed together towards focusing on these people-centered health homes and how attachment and access to primary care becomes the priority through all of the different things that you see here. But today we'll focus on the primary care. To do that, primary care networks are the term that the ministry uses. We called it a primary care alliance. If you ever look back in our previous documentation, we changed the name just because it was a name. But this is really the heart of where access and attachment to primary care comes from. It's made up of all of the various different kinds of groups that are involved in what we call comprehensive primary care. That's your cradle to grave services that you would normally, you go to see your family doctor about. We know that we have to ensure that the voices of patients, families, and caregivers are there. And so there's community council membership on our primary care network council. We include the voices of the primary care physicians. We have 19 different practices across the OHT. The lead physician of each sits at the primary care physicians council. We recognize that we have 6 family health teams and 1 community health center that's our team-based care currently across our OHT. So the Allied Health has its own council that's represented on this network. The community health center, who's the backbone of the OHT, has their own place there. Queens, as this is a learning health system, and ensuring that our human health resources and the needs of our learners are represented are there. And we pay specific attention to Indigenous primary care organizations. So this is the network that the ministry is now charging within an OHT to deliver on attachment and access to primary care. Health homes, in case you haven't heard about them to date, health homes is really the core of the work that we're trying to do. Your health home this is your main access point. Health homes will look different in different communities for different populations of people based on their needs. So it's not here's the box and everything shall fit. Here's the concept of what a health home needs to provide a particular segment of our population. It will look different on Wolf Island than it will in downtown Kingston. It will look different for people who don't have a home. It will look different for people who live in rural areas who are a half-hour drive to anything. And it'll look different for people in an urban center who might have much more access to services than people in rural communities might. But these health homes have a structure and a core set of values that apply regardless of where they are. And the idea is that the health home meets the needs of the individual community in which it's located. It creates that home base of services, but it also creates the integration and the connections to the other services that you may need. They don't need to live in a health home. Not every health home needs to have a subspecialist cardiologist, but there needs to be a pretty clear path from your health home when you need that subspecialist cardiologist to get there, that your information is going, your story is going with you, and people don't have to keep repeating themselves. This is the broader structure as we think beyond health homes. If you think about multiple health homes in a geography, create a health neighborhood. If you think about the primary care network is part of the Ontario Health Team. Primary care, those list of people and organizations that you saw in that primary care network, cannot do this alone. We can't do it without municipalities. We can't do it without hospitals. We can't do it without community paramedics. We can't do it without the specialists. We can't do it without public health. The Ontario Health Team as a whole all has a role to play in supporting these primary care networks to build these health homes and health neighborhoods that will deliver on the care that we're trying to ensure that all people have access to. Thinking about it like a school board, I think is the simplest analogy. You have multiple schools in a community. Those schools are all connected. You have special schools for special people who need those services, but it's all under the one umbrella so that there's continuity and connectedness between them. We took that to the next level around the geographic model. And again, following the school board analogy, if you take a geography such as the FLA OHT, you can create various geographies within that have different needs from each other. Again, urban versus rural, island versus not, Indigenous versus not. And so by creating these health homes and health neighborhoods close to where people live, we know the outcomes are better. So we can use geographical modeling, and we've done a lot of work with the counties and with public health, and the city of Kingston has a contract with Esri. I don't know if you guys do too, but we've built these amazing maps that can show us where people are, what their social determinants of health are, which are huge impactors to their health and wellness, what their attachment or unattachment status is to primary health care, language, culture. We can now map all of that out to say, if we were to need a new health home, where should we put it based on data? If we were to decide of the 6 primary care teams that live in downtown Kingston, where should the unattached people go? We've got these great maps. We could do a whole presentation to you on the maps about how we can truly map, how we can get to everybody being attached to primary care. These are just some pictures of the maps. I am not a GIS person, but I rely on the people who know about this to tell me. But it truly allows us in a data-informed way to develop a path towards having 100% attachment in the FLA OHT. And our goal is to be the first OHT in the province to be able to deliver on that. So this is all about why health homes are good. You'll get a copy of all of this at the end. I think focusing on what we can do is probably more important. So along comes the primary care action plan. It is not a coincidence that Dr. Philpott came from here in terms of the health home and OHT work. A lot of the things that she talks about in her book, we've been emulating here, and it's been great to have her here to sort of help build these. And then it's really great to have her now at the province talking about how do we take the pieces that we've started to build and make that province-wide. So so she was commissioned in December to join this team. In January, they announced that everybody was going to be attached to primary care within 5 years. And then they called an election and nothing happened for 2 months. Make this great announcement. It's got to be timing. So we've had the opportunity in that period of time. They've also just recently this month come out with a Primary Care Act. And these are the 6 objectives of the act, which really align really quite nicely to the principles of the health home. And again, I do not think that these things are coincidences. The goal will be to connect everybody to a primary care team. And we'll talk about teams in a minute. The goal is to have everything connected. Care has to be coordinated. We will never continue to deliver the care that people expect unless we do it in a more integrated and connected way. It needs to be timely, it needs to be inclusive, and people need to be empowered and be part of the co-design process in being able to build this. This is not something the province can say, this is how you shall do it. And I think one of the gifts of an Ontario Health Team is to really give to a community, here's the problem to solve, how are you going to do it? And it's going to look different in every part of the province, but have to be some key consistencies. But the ability for us together to be able to co-design with patients, co-design with providers, co-design with municipalities and other health sector partners on how to build this is truly the gift that we've taken on really seriously. And I'll tell you about the proposal that we've put into the ministry. These are the circles of healthcare that are the health home, really focusing on, again, empowering the people. People are the center of their care. People and their families provide 75 to 80% of the care that they need in order to stay healthy and well. And if we ignore that, if we ignore the social determinants of health, we will never get anywhere. The next round of the circles are that primary care team. Family physicians, nurse practitioners, nurses, allied health professionals, and then the other parts of the system that are best embedded: home care, mental health, community paramedics, social workers addressing the social determinants of health, really need to be embedded in our health homes to really wrap around the people that they serve. And then the outside circles are where you need those strong connections, both digitally and in ways that people have to communicate to make those referrals back and forth quite seamless. As I said, we're the blueprint in the last year and a little bit, without any net new investment except one that I'll tell you about. FLA has attached 13,000 people. The documents that came out last week while I was away suggested that Healthcare Connect attached 28,000 people last year across the province, and we attached 10,000 of them in our OHT. We are one of the smallest OHTs. But this is a testament of the collaboration and the work that we've been doing together that's brought us here, and what I think is going to get us to the last, where everybody gets attached. The one net new investment has been the Midtown Health Home, and I know that was in your report, so you know a little bit about it. That has been a separate invested of team-based funding, geared to, at its maturity, attach 8,000. And by the end of this year, by the end of this fiscal year in March, it had got to 2,400 and just opened in August. So it's on its way to attaching more, but that's been the only net new investment. The rest has all been through the coalition of the willing of primary care practices to work differently together, to make partnerships with municipalities, to make partnerships with community paramedics, to make partnerships with hospitals about how to build capacity within existing primary care practices so that the people in that practice can all work better at the top of their scope and do what they're trained best to do, and therefore, and give what other people are quite capable of doing, those other things, such that more people can be connected to each of the health homes or primary care practices that we currently have. So these are the things that we think have been the keys to success that I'd hope to focus the rest of our conversation on, about how can we take what you're trying to do in Frontenac, based on what we've done in other parts of the OHT. It's really about co-design and communication. How do we make sure that the right voices are at the right tables in order to build this? It takes leadership. It takes the right people to say, we can do this, and have the reason why of that shared vision and that shared mission to get this job done. It's all about collaboration and shared accountability. One of the things that an OHT is not yet has shared accountability amongst our partners. We talked about at the beginning, the OHT is a coalition of the willing. At the moment, it has its own accountability agreement with the ministry for very particular things. And there is nothing in any other health systems partners accountability agreement that says thou shalt work with the OHT. So the OHT itself can bring partners together. It has no funding or accountability to actually provide care. It has no funding or accountability to pay for care at this point, and it's one-time funding always. So that really is not helpful in healthcare. But its mandate is to bring people together on how their accountability agreements can be done better together, even though they remain separate. And this is a challenge. This is a big challenge in an OHT, because again, there's nothing that says you have to participate, other than that sense of collaboration and shared accountability, because we're all trying to do the same thing. Health human resource capacity is a massive issue. As I'm sure you know at your home, and in other parts, finding healthcare workers since the pandemic especially is a huge challenge. And focusing on how do we build learning health systems that all of our primary care practices are places where people can learn to work together in a team. How do we ensure that we're using the resources that exist in a long-term care home versus a community paramedics versus a social service office versus a primary care practice? There's 3 different kinds of social workers in there, and maybe there's better ways to do that together to build that capacity. And we need a clear provincial mandate and enabler. And I think in the Primary Care Act of May and the Primary Care Action Team, the ministry is committed now to actually making this a priority, which is huge. I love it when people are on the same page. Focusing on what we tactically can do operationally now. How do we ensure that primary care is supported to do that capacity? We're not going to find 35,000 more primary care doctors across this country. It's not going to happen. So how do we make sure that we've got the right people doing the right things as we build these teams? How do we make sure that family doctors are doing what they're best to do, nurse practitioners are doing what they're best to do, nurses are doing what they're best to do, social workers, etc. And in part of the work that we've done, Catherine Donnelly, who's from Queens, she's an occupational therapist. She had a CIHR grant around human health resources, and it's amazing what we don't know. Trying to understand where our current workforce is we don't know. And it's crazy that we don't know in such a system. So that's a big piece of work that we have to understand. Where are all the people, and how do we make sure they're all working in the best way that they can? Focusing on digital supports, artificial intelligence, information technology, the GIS stuff I was talking about, is important for that connectivity and collaboration to happen, but it also requires the change managers or resources to do that. It's great if you give me a new iPhone, but unless you tell me how to use it, it's not going to help me. It's only going to create more frustrations. And it's like that with any piece of technology you put into healthcare, unless the people are there to really hold the user's hands and make sure they're using it effectively, it just becomes another thing that sits in the corner that drives us crazy. So those 2 things have to go hand in hand. Recruitment and retention of primary care providers. It's huge. You need to have the place where people want to come and work. And if anything has been more clear since the pandemic, people want something different than what the family physicians of a generation ago did. You think about the Peter Bells in Charlotte Lake. Nobody is coming that will ever work like Peter Bell. He has been a gift to that community forever. 54 years, my goodness. But there are no Peter Bells, they are pretty rare if they're ever coming again. So what is it that we can do that makes people want to do comprehensive family medicine and wants to do it in a place that is further away than downtown Toronto? Be practicing family medicine in downtown Toronto, the expectation is that 5 out of 6 visits will result in a referral to a specialist. Well, in here, 1, we don't have that many specialists. 2, if we did, they're 2-year wait away. And family medicine just needs to do more. But there's a group of people who love that. So how do we get the right people going to the right places? Team-based care is part of that. And team-based care is part of that in terms of letting family doctors and nurse practitioners and every part of the healthcare system do the things that they're best trained to do. But learning to work together in a team is also different. Currently, in Frontenac, as an example, you have one family health team in Charlotte Lake. And then there's a myriad of team-based care. You've got some solo providers. You've got some people who have some team resources, and you've got some people who have none. And that change is difficult too. Again, it's kind of like a piece of technology. Unless you're taught how to work in that way, it's hard to learn and it's hard to make the best use of those resources. So again, practice facilitation, change management resources have to go hand in hand if we're going to expand team-based care. I mean, the elephant in the room is physicians are autonomous business people, and that's how the ministry have set them up. Unless they want to change, unless they're given a reason to change, they might not. But what creates the environment that attracts people who want to work in particular communities with a particular group of support? That's the key, I think, in marketing in whatever community. We talked about each different community has different kinds of health homes, and that's okay. They just need to work together. And that's where the flexibility for local design and implementation, I think, come in. And we're still in a low rules environment, which is great. So I think if we can achieve what we're aiming to achieve within this, we then get to create the rules. They're asking us already for the framework of primary care access and attachment, and it'll become part of the guidance that the ministry is putting out. It's the work that's being done here. But it's about being flexible and goes right back to that very first one about co-design and working with your partners. So that's the background of what health homes are, what FLAOHT, how it's designed, our focus on health homes and health neighborhoods and geographic attachment and modeling, and then what are the keys towards actually reaching that mission of having everybody attached. This is sort of a summary of the questions that Debbie had sent me. I know you've got an operational document and an implementation I think is coming next, but I'm happy to dive into any questions that you want to talk about.
Dr. Morrison, thank you so much for your very informative presentation. And before I turn it over to questions from council, I do want to note that I'm one of the 1,600 people who are now assigned to the Greenwood Health Center. And I'm shocked and amazed at the number of young families that are there with young children. I don't know where those folks were going before for service, but it's great to see. So again, thank you. And we'll turn it over to questions from council. Councillor Smith.
Thank you very much. That was very informative. We talk about the unattached patients, and I think it's a little different in the rural community than it is in the cities. For instance, at Charlotte Lake Family Health Team, when you move into the area, you call up the office or you come into the office and you become a patient. And I think if we're looking at how many people have become attached from that list, we need to sort of ask, how many people have you added to your roster in the past year, 2 years, 3 years? That number is phenomenal. Our doctors now, their rosters are getting to the point that they're not manageable. And Verona and Sydenham are seeing the same things. But our folks don't call up Ontario Health and say, I'm living in wherever and I need a doctor. They go right to the source and they get accepted in these communities. So I think we need to look at it another way of taking those people into account.
I agree. And at maturity, as I said, we've started with the Coalition of the Willing. And I mean, the Charlotte Lake Family Health Team has been the model of geographic modeling since the beginning, because they have defined geographic area. And if you live there, you get attached. This happens internationally. You move to a city in Norway and you get a letter saying, here's your primary care team. And by the way, you can't go to Emerge unless you've called your primary care doctor first, which I thought was kind of interesting. But it's, and that's exactly it. So in our data modeling, we can define where all of these health homes are and the primary care groups that exist currently within them. We now have the data on who the people are in each of those geographies, so we can then map what are the needs I mean, it's pretty crude data, but what are the needs? We've got some socioeconomic factors and we've got some chronic disease data. What do we think, and mental health data? What do we think the needs are for that community? So we can say, we can, for example, take the boundaries around, well, Sharpet Lake doesn't have any unattached patients, but we can take the South Frontenac County and we can say, look, you've got 2 primary care practices here that have X number of doctors. This is the unattached population from there. And if we were to say, there's 2,000 people, let's say, what would those 2 primary care teams need in order to add 2,000 patients to their roster? That's the question to the doctors. And that's the question that as a primary care network, we're trying to move forward. So we started with certain areas. We started with east of the river with Greenwood. We started with CDK clinics in the middle of Kingston. Midtown is sort of the case M&M postal code. Greater Napanee is the town of Greater Napanee. And as we've learned from that, we're hopeful to be able to say, this is how each of the other gap areas, we're calling them now, can do that. And so through the primary care action team, there was a call for proposals right when they came out of the caretaker period. So in the middle of April, and it was by invitation. So the province has started to look at these geographies truly just based on FSAs, which are forward sortation areas, which are the first 3 digits of your postal code. It doesn't work in the rural areas because they're too big. And it doesn't really work well in the urban areas because they're too small. However, they had to start somewhere and they wanted to get running at the gate. So the first application was based on particular FSAs, and their goal is to invest about $275 million in 80 new teams to meet those particular FSAs. The 2 FSAs that were identified in ROHT are the west end of Kingston and sort of east part of Amherst View. Not that all of the other FSAs don't have unattached people, but they had more than 8,000 each by their math. We, though, took the opportunity to say, oh, this is our whole OHT. According to the data, we have 30,000 unattached people. 10,000 of them are on Healthcare Connect, but we know that that's just a wrong number, so we just sort of don't pay any attention to that number. We have 30,000 people. What is it going to take to attach them all? So we went to the primary care teams and said, what would it, around your little area, there's 500 people, one of the Maple Family Health Team sites. What would it take for you to be able to take 500 more people? In South Frontenac, what would it take for you to be able to take the 2,000 people? That's just a number. I don't have the number for Frontenac, but what would it take? And we put all of that together into a proposal that would give team-based care, so nurse practitioners, nurses, social workers, occupational therapists, physiotherapists, mental health worker, embedded psychiatry, embedded cardiology, embedded pediatrics to all of our practices. It's about a net new 82 people to support all of our existing primary care teams to a tune of about $10 million. That's the summary that I sent to Debbie this morning. You're welcome to share. We should find out in June if we get approved. And if we get approved for our whole OHT, that puts us on track to have everybody attached by March 2027. So 2 fiscal years, which would be pretty cool. But geography, to your point, Councillor Smith, is the key. How do we build a neighborhood that has services that meet the needs of the people in that neighborhood? And a rural community absolutely looks different than an urban. It needs to have more outreach. People need different ways for people to be cared for in their homes. Here, home care is less available in Denby than it is in downtown Kingston. But I think that's the key is this geographical neighborhoods and having the primary care providers within them willing to say, I'll grow my practice more. Because again, it comes down to physician autonomy. And if you don't want to play, you don't have to.
Councillor Vanderwall?
Well, yes, I have a couple of questions and points. Part of what you said, we do have 2 doctor facilities in South Frontenac. So if I'm understanding this right, this family home or health home, if so, the one doctor in Sydenham says they're already out of space. The other one says they're already overloaded or with work. I mean, they're both overloaded with work. I'm not denying that part. So for my perspective, if South Frontenac build a facility though, would those doctors agree to say, okay, let's all join now together? And then it might actually attract more
More.
healthcare workers because people could have time off, people could have managed these things. So from South Frontenac's side, as looking at it from the taxpayer, what would be in it for, would South Frontenac, let's say they built this facility. Is there a way that they are compensated for building this facility without just going onto property taxation? I guess that's my question. If there's a return on investment, and I'm not saying we need to make money, that's never the point. But at least that it looks like we could build it. And as you know, the old saying, you build it, they're gonna come. But that it's just not a property taxpayer paying for it, when we all know it's supposed to be the province out of everybody's money. But does this model work that way or it doesn't?
Yeah, I mean, primary care funding is an interesting thing for sure. Built within the fee schedule for primary care is an amount of overhead. The OMA, Ontario Medical Association, will argue that it's not enough, et cetera, et cetera. However, within the fee schedule, there is an amount of overhead that should cover that. So certainly, having a central hub of which multiple health service providers come together, family physicians, some of social services, maybe the community paramedics, if there was a central place that the people of South Frontenac knew that's where you went for health and wellness. And if you live in South Frontenac County, this is where you get to go just because you live here. I mean, that's huge for the people to know that when you move here, you will be cared for. And the people that provide those services should be expected to pay their fair share of their overhead. And the value proposition of why should we do this together, I think comes out of those keys to successes. Imagine if, your physicians or your other health service providers, your addictions and mental health people didn't have to figure out their own leases because it was already done for them. Didn't have to figure out their heat and hydro and water bills. Didn't have to fix their own well. Didn't have to, sort out their own property taxes. Didn't have to deal with their own IT because that was all part of the package. So the value proposition to the providers there is that we're co-located and we can work better together. So I don't have to send somebody down the road because the paramedics are right there and they can do blood work for me right here and then. They can do an ECG for me right here and then. The mental health workers, the allied health, are right in the building. It's not like I'm sending somebody away or making a long referral that may or may not ever happen because we're co-located. So there's value to me as a family physician to be in that kind of environment. That might cost me a little bit more, but that's part of what I'm paid to do, is create that space.
Make a comment to that, though. The doctors that did the presentation said 80% of their clients are not in South Frontenac. That would be the downside. Do you do like the city then and say, if you don't live in this area code, you're out of the practice? I don't know how you would start that, but that's what they told us, I think, when we met with them, so.
Yeah. Well, and that's where, we have to start from somewhere. So for example, in Napanee, when we've brought everybody together, what we've said is nobody's getting fired from my practice because they don't live in Napanee. They've been my patient for 15 years or whatever. Nobody's getting fired. But through attrition, the only new people that will join our practices are from the town of Napanee. Once we cover the whole geography, and maybe from our partners to the east and west and their OHTs as well, once everybody aligns to this geographic model, we call it trading, and it doesn't sound right to call it people trading, but the opportunity that now exists, even it's starting now, is, people in Greenwood identified they have 70 patients who live in Napanee who have been part of their practice. I have 50 people who live the east side of the river. People have a choice, but we've gone to those people and said, you have the opportunity, you could go join the Greenwood Clinic if you'd like, it's closer to where you live. I'm not kicking you out. And they're saying the same things to their people, and we will trade. And then people are closer to where they live, and we get to a closer space of where all the people in a practice are part of that community. but that's going to take us some time to get there. But it starts with every community having a core hub to which providers will come and work. If you build it, they will come where you started.
Sorry, Councillor Greenwood Spears?
Thank you for the presentation and I appreciate the complexity of getting the circle of care actually communicating with each other and that, so your partners that are outside and that the hospitals and mental health and addiction services and things like that have always been difficult to get a good communication back and forth, to even know when your patients get discharged from a hospital. And that's so good luck with that. But it strikes me that what you're describing truly is the community health center model. And there is an envelope of funding when you get organized as a community health center, and that to get that funding for the fixed building, that's when you get the physicians in there, the dietitians, the social workers, dental, everything can come in. So to me, strengthening the wheel rather than trying to reinvent as much would be very helpful in that. That said, after more than 40 years in healthcare in a variety of settings and that, I do appreciate that the unhoused and uninsured are truly the most vulnerable group in that. And in your OHT model, I assume they still have to have an OHIP card to get service, whereas the community health centers were always funded to look after people that are on the streets, couch surfing, et cetera, and that. So I would hope that there be an opportunity to change that piece of the funding model for the family health team, because without that, the most vulnerable group are still going to be, unfortunately, left out. And on that note, I think of the influx that we have, and I know that Queens has its own health services for many of its students and that, and Armed Forces Base also has health service, but neither of them have hospitals. So the impact of influx of 70,000 additional people, and that has to get factored in at some point in time, because the private health corporations that hospitals have been meticulous at balancing their budget by closing beds. And the reality is we not only have an aging population, we have always had an underserved population because of these influences. So I appreciate that Dr. Philpott lived in the area and has that, but I really think the case for the KFL&A area and that really needs to be significantly stepped up to the point where someone's got to talk about a new hospital at some point in time. But at the very least, have a true council of healthcare connected providers so that, VON has a say at the table, the St. Elizabeth Order, the New Southeast Health Unit, the hospital, everybody, because until we get to that level, it's still approaching a piecemeal. And I appreciate you don't even get funding for the great work that you're doing that. But I really do believe when you're talking about that community of care and that the community health center was the most cost effective and well-run model of care. And I've worked lots in hospital and other settings, and that including community care. So I do hope that you look at that piece of the model, but the silos have to come down. And I've been working against silos for 30 years and that's so good luck. And if we can be of any help, I would love to be of help. And I'm sure this entire council would.
For sure. Oh, and I'm hopeful that the OHT will be that place where all of those have a seat at that table. And absolutely, the community health center model is exemplifies what true health homes are. They're built for vulnerable populations, and not all, I mean, there's different layers to vulnerability, but not everybody needs the services of a community health center either. So it's a matter of tying the right resources to the right segments of our population so that's the equity piece for sure.
Warden Lidke?
First of all, thank you for coming. I have the privilege of sitting in on monthly 2-hour sessions, and you gradually learn this stuff as you go through. And I can tell you that everyone who's on those sessions is extremely dedicated. I have one concern, though, it generally came out of what you were talking about today. Setting of boundaries, maybe they're soft or not, but like in the case of North Frontenac, we have 70 some hundred people are here from maybe May 24th to maybe Thanksgiving. Most of them come from other places in Ontario. They have a physician or a doctor somewhere else. How do they get care here without going to Napanee or Perth or Kingston or Ottawa? And I know the Northbrook Family Health Team was looking at trying to provide some of that care. I don't know how successful they were, but I mean, that's something I don't think we should lose sight of. How do we handle our visitors? Because they are significant in the summer, and it's just a fact of Eastern Ontario.
Yeah, exactly. And certainly we talked to other OHTs across the province, the Muskokas, the Haliburtons. Here, their population increases by so much. How do you plan for that piece for only part of the year?
Councillor Leonard, did you have a question?
Just to add to that, Dr. Bell would take them on for whatever that was.
Yes.
And if he couldn't, he'd send them to ER very reluctantly.
I know. And wouldn't it be great if we could have outreach from ER coming up here instead of having people to go down there? What if we could create a system where together, we could get the data from Kingston Health Sciences, Perth and LNA to say how many people come during this period of time. What if we ran an urgent care clinic somewhere, Monday, Wednesday, Friday? What would that do? And that's the power of partnerships and collaboration and leadership and co-design.
I don't believe there's, sorry, Councillor Fowler, go ahead.
Very informative. I do appreciate it. The big concern that I have is getting doctors and people to the remote locations. And that would include all over Ontario as well, especially for people like Warden Lichty pointed out, people that are traveling in other areas of the province. They need the care. Is the care going to be available? But I do like what you're doing. I think you're on the right path. Thank you very much.
Thank you.
Dr. Morrison, I think that's the end of the questions. I want to thank you for handling them extremely well. A very important topic. And on behalf of council, I appreciate that you being here and continuing the work that we need to address this critical issue. So thank you so much.
Great. Thank you.
We'll now continue with item number B, which is staff briefing from Ms. Miller. So Ms. Miller, if you want to return to the podium.
Thank you. And thank you, Dr. Morrison, for that very thorough and informative presentation. So thank you. And I'm back again following the March 19th council meeting where the operational review and the findings report were presented by Rob Wood and approved. I've been working to develop the implementation plan from that report that reflects the findings report. So as we heard, there's a lot of work happening at various levels with an application being submitted with the first round of the $1.8 billion. The implementation plan has been put together based on current conditions with the FLA OHT clinics in the province, and there are numerous factors that contribute to changes and updates. The plan is responsive and able to be adapted as things change. To move this important work forward in Frontenac County, we need to have resources and structure to manage the project. Supporting the recruitment and retention of the Frontenac clinics supports our communities, as we all know. The implementation plan is the appendix to the report and includes 7 different sections. I'm going to walk through it at a very high level. I'm not going to go line by line because there's a lot of information in there, but just at a high level just to capture some of the buckets. I put it together based on from a project perspective. So there's a lead, partners, a status, if it's in progress or complete, the task description, the approximate timeline put into quarters and only going 2025 and 2026. We didn't go further than that. The anticipated outcomes, just so that we don't end up with scope creep, so we know when certain things finish and we're moving on to something else. There may be additional tasks that are added, but we just wanted to be really clear on when certain things finished. And then the budget, some require budget, some don't, and updates at a high level. So again, I'm just going to walk through really quickly some of the highlights within each of the sections, but also noting that staff will report back to County Council with key decisions and major updates as they come up. And we will include ongoing updates in the CAO's updates at regular council meetings. So just so that it's not going to be like long periods of time between when you hear from me. So the clinic structure section is the first section within the implementation plan, and that's really the collaboration and the connection with the clinics, their models, looking at blended salary model. There's been a lot of research done by the Charbet Lake Clinic looking at the different blended salary models, and that information's been shared with the other clinics as well for information so they can review that. Those connections with the clinics have been really valuable. The collaboration, sharing knowledge and resources has been really, really important. And they've all noted that during meetings when we're getting together. Exploring the integrated health home hub in South Frontenac. Again, that's on the clinic structure section. Sharing knowledge and resources and skills. These opportunities are just being explored, and it's important to note also as we're looking at some of these pieces that we're also looking at opportunities with communities outside of the Frontenac boundaries, just so nothing's off the table. We just want to make sure we explore everything from the best possible option. We've recommended in the report this work be led by a consultant, so just noting that. The Frontenac Islands is the next section. So the mobile clinic, there's an unstaffed RV available, and the medical clinic is aware of that. Unfortunately, having a staffed unit would be the most valuable, but we're aware that that unit is available if something comes up and there's a connection there. The Rio score is another one. The CAO with Frontenac Islands recently took a report to Frontenac Islands Council and received direction to advocate for the review of their Rio score. Their Rio score currently sits at 33, so we just want to make sure that the data being used within that is accurate to Frontenac Islands. So that's just a review there. And then connecting with primary care providers to seek advanced services on the island. So continuing to make connections to see if there's other ways we can get doctors visiting the island. I also attended recently with the FLA OHT, the current state assessment with the community clinic, and there was a lot of information received there, so that was a really great session. Then the third section on here is recruitment and retention, and again, continuing to work to promote openings across platforms so that people can go to one location. The connection with EOPR, or the Eastern Ontario Physician Recruitment Alliance, is a really important one. At the beginning of May, I attended an online recruitment event, and others from that organization are also continuing to attend, whether they're online or in-person events. So that's been a really great opportunity to connect with others that are recruiting in the Eastern Ontario region. Looking at ways to collaborate and harmonize recruitment efforts ongoing, that's definitely something that we're continuing to work on. And then the NEST program, this is a program through Keys, which is a wraparound service. If we have somebody looking to relocate to our region, they would be supported through this. They would be supported with real estate, they would be supported with schools, daycare, recreation, things like that for their full family. So in order to have this service available, we have to sign an agreement with them, but it's on an as-needed basis. So we don't pay for it unless the service is used. So just wanting to make sure that we've got something in place so we can access that service through Keys. And then the last one in the recruitment and retention is exploring a potential of a recruiter for Frontenac County clinics. And again, we'll report back on that. We're gathering information, looking at different ways for that, but that would be something we'll come back to council with. The community working group, I know we brought this last time, so the initial step will put a call out to the community in hopes of getting representation across all 4 townships. Then convening that. This is another area we recommended within this to have admin support. And I would also be a part of that group that that's also recommended within there, that would be coming forward and helping to pull that group together and then getting it off the ground with the terms of reference. The support services, so this is the next section. As opportunities come up, they would be explored as needed. This was held in as a placeholder if they're needed. So some of the things that were noted were non-clinical, including IT support, potential benefits, or communications, things like that. So again, it was held as a placeholder. There hasn't been any work, but a note there that collaboration to increase efficiencies through scale was really an important part of that. So that's where that consideration was. Productivity, so making sure the clinics are connected to updates, training, and programs with the FLA OHT and through other opportunities as they come up, and helping to reduce the time spent on keeping up with new systems and updates. As we all know, we don't know what we don't know until we don't know it. So it's just making sure that we've got that information and it's top of mind. So if there's ways that we can connect the clinics to updates or training or things like that, that would be really helpful for them. And then the last section, section 7, was around communication. So various communications with the townships and the connection with the FLA OHT was really important to raise awareness within our community for certain things. The importance of rural communication, I've stressed this again, is not just using social. We know that not everybody's on social, so making sure we've got posters or signs or things like that. Also exploring the tax bills with the townships. We've had some of those conversations as well. So lots of looking outside the box for rural communication as well. This is another area that we recommended staff resource support from other staff members to support this important work. This was a really high-level overview of the implementation plan, but I just want to note a couple of things that were noted in the initial look ahead to implementation, and there was 3 things. So timing and sequencing. As noted, various tasks and projects may need to be adapted depending on what's coming down. If there's approvals or applications that are needed, obviously we know we need to meet certain timeframes, so that would be something that would be coming. The primary care action plan, we just heard a great update on where that's at and when we'll hear on that. So that's another area that we needed to be very mindful of. And then the third area was resources and budget. There are resource recommendations in the report. It would leave myself leading, being the primary contact for this project, with support from a consultant for Section 1, where they would be leading that, and additional staff support from a departments for administration and communications to also support that, where everything would funnel back into me, and then I would be reporting it out, just so there's still one point of contact. So there's the continuity on the project would be really important. The report also outlined a budget to assist with specific areas as needed. So the consultant, communications, the NEST program, and events and tours. So that was just all as needed, but asking for the approval to have that access from the special projects reserve, just so that we've got that if required. So these budget items, again, would come from special project reserve. And if there's specific questions related to the resourcing piece, I'll leave Kevin Farrell, our CIO, to answer those questions. But I'm happy to answer any other questions. I know that was a quick run through and it's a big document with a lot of moving pieces, but happy to answer any questions where I can.
Thank you, Debbie. Sorry, I keep wanting to call you mayor and everything else.
Call me whatever.
Councillor Smith.
Thank you, Debbie. I think it's so important that we keep moving. We are at the crunch right now, and with another stream opening up, we need to get our ducks in order so that maybe we can pull something together to help all of our residents, because it's getting really tough on these docks. They're at their limit. So I think we should find the money.
Warden Licky.
Thank you. First of all, Debbie, the report, what you're doing is absolutely excellent. You and your team should be congratulated. It's not an easy task to work in this field. We've had some experience, mind you. The clinic or the family health team was in Leadington, Addington, but it serves a lot of the people in North Frontenac and probably in Central Frontenac Township as well. We're always going to have trouble, in my opinion, recruiting doctors to rural areas as long as there's competition allowed between municipalities. In our case, we had a $92,000 rurality index. I think yours, Fran, is a little bit lower, but not much. But Sydenham has nothing. But Kingston can come along and say, we'll give you $100,000 to walk in the door. And that makes it tough. And in the case of us, we have, with Addington Highlands Township, $150,000 of retention money on the table over 5 years. So for small places, that's a lot. And the first thing you really need, though, is a doctor who wants to come and wants the rural lifestyle. Because even if you get them, they look around for 2 years and they leave no matter how much money is on the table, because they can make that and more, or It's just an issue, as I know you know about, but it's something I want to highlight, and I don't think we're going to, until, or as long as competition's allowed or is not allowed, we're going to be facing this problem, and it's going to cost us money. You know, unless we get lucky, but that being lucky is kind of remote, so anyway, thank you.
Councillor Greenwood Spears?
Thank you for the presentation and this actually hits back to a point, and I believe the window is still open but the county and that is actively spending funds towards healthcare, which is it's a provincial responsibility. And that whether it's from this venture or whether it's public health, et cetera, and the province has never been really held to the mat and that for something like this. And I think that we have an opportunity to at least apply for a delegation and make the point that, you know, the taxpayers are stepping up once again in order to try to secure healthcare services and it's just more and more that keeps getting downloaded, and yet the only taxation base we really have is the resident, and that compared to provincial transfer payments and provincial sales tax, et cetera. I just think we should probably take advantage to make the case, and that at the provincial level that, you know, nothing comes from nothing, and it's going to come from somebody's pocket, and it's getting put down again. And we're going to make sure that, you know, the people know that the province is technically responsible for healthcare. But I'd suggest that we look at putting an application in for delegation status at the next AMO meeting.
Any other questions from council? Wonderly.
So just a comment in response without wanting to get into a long extended discussion. North Frontenac took this very point 2 years ago to the Minister of Health at Roma, and they listened and said, thank you for your time. And 2 years ago, that was a major thrust of the whole Roma conference. This is your responsibility. It's not ours. You're downloading it, take it back. And now we're just about 2 or 2.5 years later, and we're exactly where we were before. And they're looking at it from my perspective is we'll increase the number of doctors. And at that point in time, then the pressures will be off and it'll be less impactful on the local residents. We're not going to solve this. I mean, there's nothing wrong with going to, you know, to apply for and deliver a delegation to the minister at a conference. But it's not something that you're going to expect miracles out of. They know it. They know it in spades, guaranteed.
Thank you, Warren. Oh, sorry, Dr. Borst. Absolutely.
No, you stay, I'm coming
We'll
back.
make an exception.
Okay, thank you, sorry. I have no money. No, I wish I had money, then I'll sit back down again. So I think though, your points are absolutely bang on, but the race to pay doctors to come and work has to stop. You know, it's whether it's 100, 150, that actually doesn't get people to stay. And it doesn't do anything for your providers that you currently have that you want to retain. So I think what as Debbie has talked about how do you create an environment here that people want to come and live, practice, play, all of those things that you've built together is far more important than, money speaks, don't get me wrong, and people will come, but there's no evidence that they'll stay, which doesn't help. So focusing on how can you, the money that you shouldn't have to spend, I get it, but what does your community want you to build for them to be able to access the services that they're going to need, I think is really where change can be made from a community co-design level. What does a community hub look like? What does it look like that people who come here have the supports to do what they do best, practicing medicine, and somebody else can take care of the administrative stuff otherwise? And I think focusing on that would be my advice to how to build something that will be here forever, really, for your community if you build that.
So on that note, though, maybe then if you're gonna even remotely have a delegation, maybe you should start with not competing financially for doctors. If the province could rule out that one thing, it already would level the playing ground a lot. The very first meeting we had with our newly minted MPP was do not financially compete for doctors. I'm just telling you, it will not work.
Yeah.
So that's why I've always been reluctant. But if that is more important than, I'm not saying funding isn't important, but if you take that piece away, it already levels the playing ground a lot.
Exactly.
Thank you,
Sorry.
Dr. Morrison. I don't see any further questions or comments. Ms. Miller, did you want to come back to the podium? I don't believe there's any other questions for you, but I do have a comment. I looked at your role and responsibility list, and I don't see this under there anywhere. So I assume this is as assigned other tasks, which is my kind of backhanded way of thanking you for all the work you're putting into this. I don't think this is what you really signed up for originally, but the work's phenomenal, and we need your help. And I wanted to personally thank you for all the effort you're putting into it.
Thank you very much. Thank you.
So moving on to the recommendation to approve the implementation plan, that's moved by Councillor Smith, seconded by Councillor Vandewall. Be it resolved that the healthcare in our community implementation plan appendix be approved, and further that staff be authorized to lead, coordinate, and participate in the activities outlined in the healthcare in our community implementation plan, and further that the CAO be authorized to enter into an agreement with Keys for the purpose of participating in the NEST program, and further that up to $30,000 from the Strategic Project Reserve funds be available for staff to use for consulting, recruitment events, and communications in Frontenac County as outlined in the report.
Comments, questions? Seeing none, all in favor? Approved. Thank you. So we'll now return to the regular portion of the meeting, and we'll begin with briefings by Mr. Kevin Farrell.
So good morning, Warden, Deputy Warden, and Council. As always, I'll take you through the CAO update for May 2025. I'll touch on the main points, and I'm happy to answer any questions you may have. If we can get the slides to move along, there we go. So first off, just to highlight a few items from my May schedule. On May 5th, we welcomed 3 summer student interns. I can relate as I started my municipal career many years ago as a GIS summer student in Hastings County. So I'm always keen to welcome our students, and we have another great group this year. So a big welcome to Jenna, Sarah, and Alex. Warden Lichty and I did some work prepping for and attending meetings at Queen's Park in Toronto, May 12th and May 13th. I'll speak to this a little more later in the slides. And yesterday we had a very productive FMSC board meeting with one key highlight being that was the approval of the shareholder agreement. It was reviewed in detail and updated by the Frontenac CAOs group. And next it will need to go to each individual council as well. In terms of a human resources update for recruitment, we had 169 postings as of May 12th. Ongoing recruitment in all areas of Fairmount, and 15 part-time paramedics started with us on May 12th. Labor relations, QP 2290, we continue to wait for interest arbitration. OPSU 462, our paramedic group, will begin bargaining in July. And QP 109, that's our ferry group, our marine services. We have a third date of bargaining planned for June 12th. Under miscellaneous, equity, diversity, and inclusion, the committee kicked off on May 5th with valuable discussions and ideas that we'll be following up on. We had a conflict resolution workshop offered internally on May 1st with 20 attendees. It was very well received, and a second date will be offered as well. So big thank you to Barb McCulloch on that. And we also have a wellness fair planned at Fairmount Auditorium on May 27th. Which council is also welcome to attend. On April 30th, the management team at Fairmount Home met with Groundworks Engineering to discuss the progress on the replacement of the wastewater treatment system for Fairmount Home. A feasibility study looking at proposed systems is anticipated in June. Fairmount Home has entered into a partnership with the Independent Order of Odd Fellows and Rebeccas in Harrowsmith. This will allow the home to donate surplus mobility aid equipment to benefit the community. On May 8th, Peyton Hunt, Assistant Director of Care for Infection Prevention and Control, attended a public health event where she presented on flu fighters and tackling influenza in long-term care. A big thank you to Peyton for her leadership and sharing guidance with our partners. Nursing Week was May 12th to 18th, where we celebrated the impact nurses have in shaping healthcare, and a big thank you to all the amazing Fairmount staff who provide exceptional care to our residents. A few updates from the Frontenac paramedics. As mentioned, we welcome 15 new paramedics who have started their orientation. Paramedic Services Week is this week, May 18th to the 25th, and it's an opportunity to reflect on and celebrate the contributions of our valued paramedics and the important work they do in our community. The new dispatch system, MPDS, is helping with operational improvements, and we're also seeing improvements in offload delays since experiencing a spike at the end of 2024. So that's some good news there. In terms of communications, measurable digital engagements for April. This is where users actively interacted with our published material. This was up 15% from the same period a year ago. And the most watched video across our channels was the This is Frontenac video, the tourism video. And the most visited web page was our employment and recruitment page. A State of the Waterfront survey is now available on Engage Frontenac. It will help gauge how people use waterfront spaces, what they value, and what concerns they have about development around these spaces. Planning applications were at a normal level for April, but staff have seen an increase in applications and inquiries since the start of May. A few updates from economic development. A successful business network event was hosted in Cloyne on May 14th. With 33 attendees, and the team also visited an additional 4 North Frontenac businesses following that event. A huge thank you to Debbie Miller. As you just heard earlier, a lot of work has gone into the healthcare in our community file, and we appreciate all the efforts that have been involved in that. There's an upcoming FAM tour planned for Wolfe Island on June 3rd. The tour is a collaborative effort with the business community to raise awareness on how to access Wolfe Island, whether that's walk on, drive on, cycle on, and all there is to see and do for residents and visitors. A quick update from the KMP Trail. On May 10th, there was an ATV Ride to Wheelers event with 116 participants. In March and April, our partners with Frontenac ATV Club provided over 400 hours of volunteer time to assist with trail cleanup after the ice storm, and numerous washouts have been repaired, and grading and dust suppression efforts will begin in early June. As mentioned earlier, Warden Lichty and I attended the Eastern Ontario Wardens Caucus Queen's Park Advocacy Day on May 13th. We participated in various meetings focused on strategic priorities for Eastern Ontario, including economic resilience, investment in municipal infrastructure, and housing development. EOWC members met with various government officials, and the warden and I were personally involved in meetings with Premier Doug Ford, Minister of Infrastructure Kinga Surma, Associate Minister of Forestry Kevin Holland, as well as MPP John Jordan, Ted Hsu, and Mike Schreiner. And finally, a big congratulations to our talented GIS team, Anand Sharvin, Christy Elderhurst, and Robin Quick, who recently accepted the 2025 B-Spatial Ontario Award for Best Small Organization. The award acknowledges the outstanding achievements of small organizations with up to 3 staff that have showcased exceptional capabilities and impact in geospatial and information services. So huge kudos to that team for their work. And we'll take a moment here to show off the award and a photo with the warden. And that brings me to the end of my report. And as always, I welcome any questions.
Thank you, Mr. Farrell. Counselor Vanderwall.
Just so that if they're listening, I am not opposed at all to the Rebecca's. I'm just wondering why, if we were gonna get into a program like, or whatever you wanna call it, why it wouldn't have been connected with North and South Frontenac Community Services. They know the people that need all of these things. I'm not saying Rebecca doesn't, but I think they would have a narrower scope of the need. I'm just curious. I mean, maybe they approached the county. I'm just curious why it went that way.
Yeah, so I believe they did approach the county with that specific ask and need. I believe the agreement is for 1 year. We can always revisit those things, but if Susan has anything to add, you're welcome. But that's how we ended up where we did.
I was just going to confirm, yes, everything that the CAO said is correct, that they approach the home, but I certainly can also approach the other organizations and we can perhaps share the aids. So thank you.
Sorry, Counselor Greenwood Spears.
Yes, thank you. And that think probably the counselors would be surprised at how many pieces of equipment are currently in storage and that, and so organizations that have international reach may actually turn around and ship some of these pieces to other countries or places that are in the north or in high need and that. So it's not that the population of the Harrowsmith area could even begin to handle the amount of equipment that quite frankly is sitting in storage, and that after somebody passes away and is left, and that it usually is actually quite problematic. So having a good group that wants to take it off your hands is actually advantageous.
Warren Lickey.
Thank you, Deputy. Two comments. First is more of a question, and that's Groundworks. Is that a system that we can possibly use some of the Nutera or similar technology, or is that a system that we are using?
So when we met with the Groundworks folks, they're exploring different options and the technologies around what will work on this for this facility. We also met with them and discussed how far along the utility has come and explored some of the options for this entire campus. So some of those considerations are being made as they work through that feasibility study.
Thank you. The other part is the KMP trail ride. I joined them for lunch, and it was impressive. 70-some machines. They had it spaced out with the lead rider and all of them coming behind about half a kilometer back. They had trail wardens throughout it. They had they didn't have an AFib unit with them, but they do have one. They've been gifted a second one, and it was one of the most professionally done things I've seen in a long time. I think we made a good choice. So,
Counselor Smith.
Just want to follow up on Ron's comment. Would it be possible to make a list of items that aren't going to be used if the Oddfellows Hall doesn't want it, that Rural Frontenac Community Services and the Grace Community Services could have a look as to whether or not they could use it? Because I know I send people to Rivka's all the time to get walkers and all kinds of stuff. So if there's extras, be nice if there was a list so we could say, we really could use that because we have somebody now that needs it.
Absolutely, and I certainly will make sure that that is done in the very near future and provide them the opportunity to come in-house if they wish to have a look at them as well.
See no other questions? Mr. Farrell, thank you for your report. There's request to adjourn for 5 minutes, 7 minutes. So,
Unmute. That's too late for that for now.
Thank you, Counselor. Regular council meetings is resuming at 10:36. 10:56. Thank you very much. The next item on the agenda is unfinished business. There is no unfinished business. Consent reports from the Chief Administrative Officer. I should have gone for that coffee, sorry. There are none. We will now move into Committee of Management of Fairmont Homes.
Moved by Councillor Leonard, seconded by Councillor Gowdy, that Committee of the Whole Council adjourn and meet as Committee of Management of Fairmount Home with the Deputy Warden in the chair.
All those in favor? Passed. Item 2025-048, Fairmont Home Q1 Quarterly Update Report. Any questions on that report? Seeing none, all those in favor?
Just for information.
Thank you very much.
So moved by Councillor Greenwood Spears, seconded by Warden Lichty, that the Committee of Management of Fairmount Home now adjourn and revert back to Committee of the Whole Council.
All those in favor? Approved. Sorry, we have completed recommended reports from the Chief Administrative Officer. We'll now move to information reports from the Chief Administrative Officer, A 2025-046, Corporate Services, Queen's University Archives Annual Report to the County of Frontenac. Any questions, comments? Seeing none, item 2025-047, Corporate Services, 2024 County of Frontenac Investment Report.
Councilor Vanderwall.
Councilor Vanderwall has a question.
I guess when I was looking at it, I was a little bit surprised at how long you locked the terms in. I would assume you don't think you're going to need the money. But if we did, 2029's, I know it always comes quicker than we think, but I was a little bit surprised at some of the large amounts that were locked in that long.
Yeah, and in the absence of the treasurer and deputy treasurer, so we've been following that, the policy, and we assess and work with our investors group to ensure that we have the funds on hand, cash in hand, and aggressively are investing in what's proven to be successful to this point.
Councilor Greenwood Spears.
Yes, actually, I was quite pleased that they had secured that high of an interest rate, and I think we all knew the interest rates were going down. So the point being that they were aggressive in getting that length of loan, and in reality, if there were a great circumstance in that, we could take the penalty in that and get out of some of this too, in that you can always cash out, but you miss out on a lot. So my only question is, the interest rates, is it being paid on an annual basis to us, or do we have to wait to the end? Because I kind of hope it comes on an annual basis, and that could actually flow into our budget.
Again, in the absence of the treasurer and deputy treasurer, I believe it's they mature at the end of that term, but I can circle back on that answer for you.
Any other comments or questions? So seeing none, those reports are received. Next item on the agenda is reports from the Advisory Committee of County Council. I'll remind the council that the report is subject to one motion. If there's any member who chooses to pull us individual items out, that should be done now before we move forward.
So through you, Deputy Warden, there is just one item on this governance review report. That's just a standard clause that we put in there, but there's just the one item, I believe, on this one.
I'm glad we're enjoying our job. So the report of the Governance Review Committee. The Governance Review Committee report and recommends as follows.
So that's moved by Counselor Fowler and seconded by Counselor Leonard that the report received from the Governance Review Committee be received and adopted. And the item on that is the accountability and transparency policy.
Comments, questions? Seeing none, all those in favor? Approved.
Moved by Counselor Gowdy, seconded by Counselor Greenwood Spears that council revert from Committee of the Whole Council to council.
All those in favor? Approved. Thank you.
Josh, report of the Committee of the Whole.
Moved by Deputy Warden Saunders, seconded by Counselor Smith that the report of the Committee of the Whole Council be adopted and that the necessary actions or bylaws be enacted.
Any comments? In favor? Carried. Do we have any notices, or motions, notice of which has been given? None. Anyone wish to give a notice of motion? Seeing none. Communications? The council consent to the following communications of interest to council listed below be received and filed. Okay. Other business, bylaws.
Moved by Counselor Vanderwall, seconded by Counselor Fowler that leave be given to the mover to introduce bylaw A that has been circulated to all members of County Council and that bylaw A be read a first and second time.
Comments? In favor? Carried.
Moved by Counselor Vanderwall, seconded by Counselor Fowler, resolved that bylaw A be read a third time, signed, sealed, and finally passed.
Comments? In favor? Carried.
Moved by Counselor Leonard, seconded by Counselor Gowdy, that the meeting hereby adjourn at 11:04 a.m.
Comments? Carried.